All right, so this is going to be a brief overview of fluids. What you want to start looking at as we start discussing the different nuances with fluids is understanding the terminology of cellular versus extracellular. So 2/3 of our body's fluid is within the cells or intracellular. Our extracellular fluid is about 1/3, and that includes interstitial, which is the fluid between the cells but outside of the blood vessels, and intravascular, vascular meaning vessels. So that's the fluid that your blood plasma, your intravascular fluid. The next thing I want to talk about with you guys is one of the areas that often is a muddy point for students. It's Starling forces. These forces work in opposition to each other, hydrostatic and oncotic. So we have our capillary hydrostatic and our capillary oncotic pressure. We have our interstitial hydrostatic and oncotic pressure. So remember, the hydrostatic pressure pushes water out of the capillary. It's the pressure that's created by fluid when it's in a confined space, and oncotic pressure pulls it back in. So hydrostatic pushes out, oncotic pushes in. We can measure these pressures to kind of see where things are within the cell. The difference between the measured pressures decides whether the water is going to leave the capillary or whether it's going to be pulled back in. So it kind of keeps that equilibrium. So hydrostatic pressure in the capillary changes the blood movement through the capillary, and some fluid loss can occur. The oncotic pressure in the capillary occurs when displacement of water by plasma proteins happens, and it's going to create a concentration gradient between the blood. The fluid that's pushed out of the capillary wall by hydrostatic pressure is called filtrates. So you'll often hear us talk about filtrates. So the forces that favor filtration are capillary hydrostatic pressure, and the forces opposing are capillary oncotic pressure and interstitial hydrostatic pressure. So I hope this helps with Starling forces. So the next thing we want to look at is movement between intracellular and extracellular fluid. Movement of fluids between the various compartments occurs in one of two ways, either passive transport or active transport. There you see listed here the different forms of passive transport, and then you see the different, the movement of anything against a gradient using energy is active transport. So anything not requiring energy is passive. If it requires energy, it's active. So again, passive transport occurs spontaneously through any semi-permeable layer and without the use of energy. Active transport occurs as a result of the use of energy. An example is a sodium-potassium pump that many of you should remember, all of you should remember from anatomy and physiology. So that would be a form of active transport. So passive transport includes diffusion, osmosis, and filtration. So diffusion is a form of passive transport that is simple movement of solutes from high concentration to low concentration. An example of this is in the body is the movement of oxygen from the lungs alveoli into the oxygen depleted red blood cells. So it's oxygen movement from an area of high to low concentration. Osmosis is the movement of water from an area of low solute concentration to an area of high solute concentration, and we'll talk about that a little bit more. In the bloodstream, these solutes are primarily sodium, urea, and glucose. Water is going to move in an attempt to equalize the concentration differences between the extracellular fluid or extracellular space and the intracellular space. Whenever water moves into or out of the cell, it does this because of osmosis. Osmolality is the measure of osmotic pull exerted by particular particles per unit of water. Clinically, it's going to be expressed as milliosmoles per kilogram of water, and the normal serum osmolality range is 280 to 294 of the milliosmoles per kilogram. Filtration is the movement of fluid and solutes out of the arterial end in the capillary bed into the interstitial spaces due to pressure differentials. These different differentials are the result of the following forces: the hydrostatic pressure, which we just talked to, again, the pushing force of fluid against the vessel walls, Gravitational pressures, pumping pressures of the heart, and osmotic pressures all contribute to the pushing force. And then the other is a result of colloid osmotic pressure, also known as your oncotic pressure. That's the pulling force of fluid into the vascular system caused by the high concentration of protein solutes, which are your colloids. The presence of albumin protein in the bloodstream is an essential solution that makes up the colloid osmotic pressure. Tonicity. This is something you'll be talked about through pretty much all of the courses, because the tonicity is something that determines how we treat, what type of fluids we give a patient when they get IV fluids. So isotonic is the same concentration as the body's fluids. Alterations that you see are related to, in this, so an isotonic issue, so any alteration that's an isotonic alteration is going to be the direct result of something that loses volume. So it can be dehydration, it could be hypovolemia. So loss is pure plasma or extracellular fluid. The concentration of the solutes is not impacted. This occurs with patients who have burns, hemorrhage, or inadequate intake. Those are some of the possible causes. Hypotonic is the solute concentration is less than that of the body's fluids. Alterations are usually a result of extracellular fluid osmolality being low, which is caused by hyponatremia or water excess. And sometimes it can be both. Hypertonic tonicity, the solute concentration is greater than that of the body's fluids. Alterations are the result of extracellular fluid osmolality being high. Major causes are hypernatremia or water deficit, so they're opposites of each other. Fluid volume deficit, causes of this, so it's insufficient fluid in the body. So what can cause a fluid volume deficit? Vomiting, diarrhea, fever, GI suctioning when we're suctioning our patients and we have them on low well suction of their MPO, sweating during warm weather, decreased intake, increased caffeine or increased alcohol intake, hyperthermia, diuretic use. Elderly patients are at risk for this because they have a decrease in body water and often have difficulty regulating sodium-water balance. That's a normal thing with aging. So they're always at risk for this. Signs and symptoms are going to be a rapid, weak pulse, rapid respirations, hypotension, weight loss, emaciation, dry mucous membranes, increased hematocrit and increased urine-specific gravity, and often concentrated urine. They'll have postural hypotension, which means their blood pressure is low when they change positions. Oftentimes you'll see that they feel dizzy or lightheaded when that happens. Decreased skin turgor, so they have tenting of the skin, increased sodium and BUN, and hyperthermia. Fluid volume excess, causes of this, so this is excessive fluid in the body. Causes are isotonic gain, increase in interstitial compartment, increased intervascular compartment, heart failure, renal failure, cirrhosis, excess ingestion of sodium, and IV fluid that is infused too fast. Signs and symptoms of this are going to be pretty much the opposite of fluid volume deficit. So this, we're going to see increase in bounding pulses and increase in blood pressure. You're going to see an increase in the respiratory rate. A lot of times they're really short of breath. They have all this fluid everywhere. You'll hear crackles in the lungs many times. They'll get jugular vein distension, so their jugular veins will be sticking out, and oftentimes you can almost see the pulse in those distended veins. Decreased hematocrit and BUN, edema, which we'll go on to next, and weight gain. And then we have edema. So edema is the excess fluid in the interstitial space. There's pitting and non-pitting edema, and there's different types of edema. So causes of edema are venous obstruction or sodium and water retention. The types that we see are localized, which is found at the specific site. Something that would be an example of that would be a sprained ankle. You have generalized edema, which impacts the entire body. You have dependent edema that's related to positioning and depends on gravity. So that might be pedal edema, like edema in the feet if someone's sitting for a prolonged period of time with their feet dangling. You can also see this sometimes when you have patients who are laying in one position in bed. You'll roll them over and you'll see that they have edema in the sacral area. And then pitting versus non-pitting. You'll see, look at the pictures in your textbook. You'll see there is pitting is when you push down and the indent stays in that place. Non-pitting is when they're swollen, but when you push, there's no indentation. So that's it. As always, make sure that you guys are looking at all of the terminology, get to know the terminology, and use the resources within your modules.